Understanding CKD is important because you diagnose it early and you take measures early. You have some measures that prevent the progression of CKD. Suppose if someone has diabetes in adult, hypertension, if this disease remain in control, progression of CKD can be delayed or can be halted even. Say that thereby in pediatrics in children also you have this sort of scope. So take the opportunity of those scopes and diagnose it earlier and take measures to stop the CKD development and end stage. Creatinine is a fallacious biomarker, quite a long, and other biomarkers like cystatin C and gel, they also have some your pitfalls to diagnose CKD. So thereby, so definition of CKD is made in such a way structural and functional abnormalities that last longer than 3 months with implications on health is labeled as CKD. That is a structural change. A person who, suppose in children, ARPKD, or the gross hydronephrosis, obstructive uropathy, they are known. Some of them are very quite large and severe. That is developing CKD is almost certain. In those cases, if you see these structural changes, the creatinine is normal. You diagnose CKD because it is almost universal. It was coming. Similarly, functional abnormalities like proteinuria, your hypertension, your hematuria, sedimenturia, albuminuria criteria more than 30 milligram per 24 hours per 1.73 meter square, and ACR more than 3 milligram per millimole. So, in a child who has Alport syndrome, or adult who has diabetes, hypertension, it is CKD basically. It's going to happen. It's going to come. Thereby, you diagnose it earlier and you take measures. Similarly, sedimenturia, for example, in Alport syndrome, you know, uh, in hypertensive nephropathy, you have hematuria. So you have proteinuria and increasing proteinuria. You diagnose CKD. Be cautious and take measures to control the disease if it is controllable. For example, the hypertension it is controllable, diabetes it is controllable. So do that. Electrolyte changes that happens in some of the diseases. For example, suppose a common distal renal tubular acidosis, or they are a bit less common, the DEN disease. You have distal tubular acidosis features and proximal tubular acidosis features. So thereby you have, that means you have hypokalemia, metabolic acidosis, and you have hyperchloremia. You have this diseases diagnosed by dint of other success. So dent is by CLC and gene mutation identification and others means. So if these features are consistent with and you have yeah, features of the early feature security, even without when it's invariable is coming, so you diagnose these things and take measures to control the disease as per the highest level of science. Also, the genetics has some rules. For example, as I said, the CLC5 gene in the DN disease is diagnostic. At times you are helpless, but good amount of time you have some help, which will help you to prevent the CKD progression, and there are halt it. For example, stage 2, 3, 1, you halt it for quite a long, for 10 years, 5 years, even longer. So take the opportunity. Histological diagnosis, for example, the FSGS, 50% or something, they go on developing CKD. So thereby you diagnose it earlier by doing one biopsy, one genetics, and so and certainly the transplant and previous history of the RRT is diagnostic. So these are the ways and means that you can understand your CKD earlier, and you can take the measures to halt the progression of the disease further into CKD 5 and 5D.